hoped it had come up on here, but come out of that and go back in again. So guys, we are dead on the dot. Amy has got, hi Julie, hi, oh, who else? Hi Jane. Amy has got half an hour, so we are going to use her time well. Hi Kerry. Okay, so I think first off we said you're going to just do a little explanation about who Amy is and how she got to become a specialist in her field, and then we can sort of start tackling some of the questions.
Let's do it.
Yeah.
So hi, I'm Amy Lewis and I am a GP in Wallingham, but I also work as a menopause doctor. So for my NHS patients I see them in the GP setting, but I also work for a company called Menopause Care as a menopause specialist doctor. I have got into it probably a little bit accidentally, in that more and more I was seeing it in work and thinking this is really fascinating and I don't know enough about this. So I went off and did some extra training. Really enjoyed that. And then did some more training and then a little bit more training.
Yeah.
And I've just got increasingly into it. And thank goodness the profile for menopause has finally been raised, and it's become really obvious that we're not taught about it at medical school, really. It's just maybe an hour in gynecology it's mentioned, and
probably quite daunting for a lot of GPs as well. They're getting bombarded with so many questions and actually not being able to give perhaps the answers, you know, at that time. It's and then it's another wait, isn't it, to see somebody else? So
absolutely, and it's horrible not to know the answer or not to be able to help somebody if they want the help. But now it's being introduced much more in medical schools, so it's really filtering down that there is much more education for it. So that's my role. So I do lots of women's health in work as a GP. I guess because I am a female GP in my 40s, so I attract people. And then I work exclusively in a menopause clinic as well.
And then you've been doing some work with the Menopause Care team as well?
Yes, so Menopause Care is a private company set up by Naomi Potter, who wrote the book with Davina.
Yeah, girls, you know that. I think we've spoken about that before.
And she has handpicked doctors who have a big interest in extra training in this area, and we work as a really tight team, and we've all got special interests then within menopause care.
Yeah, fabulous. So, although we all know what the menopause is, I think there's still a lot of confusion around the stages of menopause. So, do you want to sort of talk us through that?
Yes. So, the menopause is a one-day event. It is the one day on which you are 12 days from your last ever period. So it's one day, that's it. That's the menopause. From there on, you are postmenopausal, free to live your life as a postmenopausal lady. The run up to that, from the minute you have any changes, any symptom, be it a hot flush, a bit of vaginal dryness, the biochemical or the internal changes start, that's when you're perimenopausal. And that can go on for a decade.
And that could be even if you're still having regular periods.
Yeah, totally. And having regular periods does not mean you can't have HRT or treatment for your menopause at all. Often it's one of the things that goes last for women. So it does not mean you're not perimenopausal.
And somebody did pose a question today, actually. They said, you know, I've got these symptoms, I've had them for years. Is this it now? Are these symptoms going to last forever?
No, and I think that it's I've started to talk to people about their menopause journey like marathon training. That there's ups and downs with it. It waxes and wanes. You might have a little injury along the way with your training, but it is a real journey. And the symptoms that really trouble you initially might really go and then might be replaced with something else. And eventually bodies do adjust to having the drop in the hormone. So no, that's not your life forever. And also there's no reason why we should not find ways to help our symptoms these days.
Which is kind of what we're doing, ladies.
Yes,
you know,
absolutely.
we're laying the foundations as such. So with regards to the three hormones, do you want to sort of talk us through that as well? So
there are three female hormones. So there's estrogen, progesterone and testosterone, all really important. When we're starting our periods, having babies, before we hit 40, we have loads of these hormones circulating, really high levels, and we live all our lives with those really high levels. When we hit about 40, if you were to look at the graphs, it literally does that. And that there is our perimenopause, and that's what we're feeling when we suddenly, I find my car keys in the fridge, or, you know, I look at my child and think, which child are you? You know, that sort of feeling of calling everybody's name.
Yeah.
And that's what we're feeling. If we think about estrogen, estrogen is essential for periods, ovulating, pregnancy, but there are estrogen receptors everywhere in our body.
Right.
So, you know, people getting palpitations, can that be to do with lack of estrogen? Bladder symptoms, changes in your period, achy joints, they're literally everywhere. Progesterone, a really important hormone for menstrual cycle, but also plays a role for some women in helping lower anxiety and sleep. It helps maintain pregnancy, but it does have other roles as well. And then testosterone, I think probably if we were doing this in 5 years' time, I'd be saying loads more about testosterone, because there's still a real lack of data and evidence on it. But we know it's important for mental clarity, mental bite, you know, that kind of sharpness of thought, muscle strength, motivation, libido. The big one is libido, but all those other things as well. So they're all really important.
So I think estrogen's probably the one hormone that most of us can kind of understand. But I think progesterone, for instance, some people say to take it before you go to sleep, take it on an empty stomach. For some people it gives them a lovely calm sleep, that calm feeling that you mentioned, or helps reduce anxiety. But then other people find that it does sometimes the opposite.
Yeah, so there are some women who are really progesterone sensitive, and so the sort of side effects of progesterone are those ragey PMT type symptoms, and some people will get a bit of PMT, some people will have a really horrible time with it. And often women will have an idea. So if for instance, if they are on HRT and they're on sequential, so when you're on estrogen all the time and then half the month you're on progesterone.
And that's when you're still having periods.
When you're still having periods. So people might say, I feel great when I'm in my estrogen only, and I can really feel the difference when I'm on progesterone. So, but there's ways around that. So if people are getting symptoms when they're taking the tablet orally, you can often use the tablet vaginally to get rid of the symptoms.
The progesterone?
Yeah, because it's absorbed into the womb, acts on the womb, but doesn't actually get into the bloodstream as much to give you the side effects. And the Mirena coil can be a very good way of navigating.
Yes, because a lot of the ladies, if they've got the Mirena coil, will then are taking the estrogen as patch, gel or spray, whatever they're doing. But I think that's, with the progesterone, you often do hear some women saying, I'm just not looking forward to having my 2 weeks of progesterone, because I can really feel that difference in my mood and everything else. So it's quite interesting to know that there are other
strategies, and I think it's really worth clocking that and reporting that, because it's not one that you need to suffer in silence with, because there's you know, often you have to try different things and be patient and know that we might need to try that one. There are, and not all progesterones are the same, so you have synthetic ones. Obviously all hormones that we make and give are made in a lab, but some are more natural than others. So the micronized progesterone that some of the ladies might be on are derived from yam, and it's as molecularly similar to what we naturally produce.
So they're our body identical.
They're body identical. So, you know, we have body identical, and then there's bio-identical HRT. So I'm British Menopause Society trained, so I use body identical. Bio-identical, you can't get on the NHS, it's all private, and it's when you have compounded things. So you might get a bit of HRT that's got estrogen, progesterone, and maybe a bit of testosterone in it, but you can't regulate it, because you know you can't tell how much of everything.
It's just that much you've got, and that's it.
So that's why I wouldn't use it, because I'm all about the safety.
And the body identical is, as I understand it, the safer route of HRT.
Absolutely.
We've kind of gone on to HRT here, probably. I don't know how many of the ladies exactly are on HRT. I know some of them are, some of them aren't, but do you think maybe should we run through these questions and see where we go with those? Hi Sheila, hi hi Nicola. Can we make an appointment? I told you they'd say that. Can we make an appointment with Dr. Lewis? Dr. Lewis is local at Wallingham, so hang on, it's quiet. So can I get? Is it quiet? Can you hear us? Hi Lou. Is the volume all right? Move it a bit closer.
Maybe am I being a bit quiet?
I'm just gobby. I think they're used to me being gobby.
I'll speak up.
Okay.
Am I quiet?
Yeah, no, that's all right.
Okay.
They said that's fine. Hi, Ruth. Hi. Which one, Church Road? They're all hunting you down.
Church Road.
Church Road, Wallingham Green Medical Practice. But you know, there should be GPs. You know, I think whatever route you decide to go down, ladies, and I think what we're doing now is I think Dr. Lewis or Amy. Amy would always probably suggest to her patients is to lay the ground foundations down first, which is exactly what we're doing, and then anything else alongside that is a conversation you have with the GP. And if you're not happy with that, I mean, the balance app I spoke about, so then that's probably good to go in armed with that, would you say?
Absolutely. And actually, there's a lot of stuff that can be done before you go into that appointment to really help, because we have these silly 10-minute appointments. So if you go in, questions you'll be asked are what your symptoms are, how long they've been going on for, when was your last period, do you still need contraception? And then it's around what you're hoping to achieve. If it is that actually I just want a bit more energy, or, you know, my hot flushes are completely debilitating, I've got terrible vaginal dryness. You know, I think we all need to be talking about vaginal dryness more, because it's nothing to be ashamed of, and it happens to almost all women. And, you know, teach our children to say vulva, because there's nothing wrong with saying vulva. Go in with those symptoms, go in knowing what your options are. And we were talking earlier, weren't we, that it's really important to know what your personal risk is. So, you know, if you know that you've got family members with breast cancer, be curious and find out, was it just my mum? Are there 2 aunts as well? How old were they when they got diagnosed? Those are things your GP will need to know. But yeah, absolutely, it's all about the foundations and working out what you want to achieve out of this.
Yeah, I think there's a lot of sort of confusion as to, which is why I mentioned the body and bioidentical people. You know, I mean, even my understanding is the body identical is a safer route of HRT. And actually, you pulled something up, didn't you?
Yeah.
On screen. Now, ladies, I don't know if you can see this. I can probably.
Okay, if you want to try to get it.
Let me bring my phone down here, and we'll shine it on there.
So we flipped straight onto breast cancer because I think we get asked about it all the time. In 2018, the National Institute of Clinical Excellence produced new guidance on managing the menopause and perimenopause. And they also worked alongside the Women's Health Concern Initiative to talk about breast cancer risk. And they produced this brilliant schema that I use. I tend to bore my own patients with it, because it's about understanding HRT risk and breast cancer versus lifestyle risk. So they looked at 1,000 women between the ages of 50 and 59 over a 5-year period, some of whom were on HRT and some of whom weren't. And the figures showed overwhelmingly that the greatest risk factor for developing breast cancer wasn't HRT, but was being overweight. There were 24 additional cases for women with a BMI of 30 or more. Smokers have got higher risk. People who drink more than 2 units of alcohol a day have got, is that five extra cases?
5 extra.
And actually, if you're on estrogen-only HRT, there's 4 fewer cases. So it's the progesterone in the HRT that is thought to be the issue. Remember, HRT doesn't cause breast cancer. It'll make it grow if there's breast cancer there, but the progesterone is the problem.
Yeah. Do you understand that, ladies? It's the, say that again, sorry, Amy.
So the progesterone is the problem. Estrogen will make estrogen receptor positive hormone grow, but it's the progesterone that's the issue initially. That said, these 2018 figures were based on when we didn't have the very breast-friendly progesterone, the Utrogestan. So these figures these days, because so many women are on the less synthetic progesterones, will probably be lower.
Yeah. So the risk factors are actually not high, are they?
No, I think it shows us, doesn't it, that if we really get healthy, and sorry, there was another one that was even better, that if you do 2.5 hours of exercise a week, not a day, and moderate exercise in a week, there are 7 fewer cases. So there's so much lifestyle stuff that can be done.
That's interesting. Okay, so let's sift through, because we are kind of halfway. Let me just double check. I will send you a picture of that. I'm sure Amy will. I can probably Photoshop it. I'll put it in the group, so don't worry.
Brilliant.
Okay, Nicola, what about the Marina coil?
I love the Marina coil. I'm Welsh, so I say Morena.
Morena.
But I know in England you all say Marina. So what about how good it is?
Do you mean is it safe, Nicola? I think she's talking about the progesterone, yeah.
So it has got one of the more synthetic progesterones in it, but in the grand scheme of safe, yes. You know, it isn't a super breast friendly progesterone, but it is still in the big scheme of risk factors, low risk. And remember, it's always weighing up, you know, putting you one risk versus another. So the Mirena is brilliant for reducing your risk of endometrial thickening leading to endometrial cancers. So it's weighing up all these risks and benefits all the time.
Okay.
So me talking about the micronized progesterones and how breast friendly they are doesn't mean that I'm sort of down on the more synthetic ones.
Yes.
In terms of breast cancer risk, the micronized are the safest for that, but not necessarily as effective as the Mirena for keeping the lining of the womb nice and thin.
Right, gotcha. And progesterone is for that, isn't it? Just to keep the lining of the womb healthy.
Yes. So if you just have estrogen, the lining of the womb will just get thicker and thicker, which eventually could lead to abnormalities in it and eventually could lead to cancers. The progesterone's role is to keep that in check.
Yeah, fantastic. Okay. Somebody just said, how long should we log symptoms before going to see to doctors?
Doesn't matter. Doesn't matter. If you feel not yourself, you know, if you're over 40 and you're thinking about could this be perimenopause, go and start having the conversation.
Yeah. And then there's someone else has just said she went to see a GP, but she'd had a stroke, so she wasn't sure what she could take. But they put her on a HRT.
Great.
So yeah, I have endometriosis. When do I get to the? You've cut off there, Em. I've only just started using it. Patch gel also. Yeah, Amy, the options with the estrogen, it's patch gel and spray
and tablets.
And it actually is really, somebody said what's the best. I think it's down to absorption, isn't it? And what works for you.
Yeah, so I'm a big fan of the transdermal, through the skin, so the patches, the gels, the sprays. You can even get implants in some special clinics for people who don't absorb. Yeah. So I prefer those because they obviously they don't have the risk factor for clots.
Yeah.
But yeah, there's not a one size fits all, and oftentimes you end up changing things because you might start with the gel and then you might find actually it's too much of a faff for you in the morning and go to a patch. Some women find that their skin reacts to the patch, so it's being open-minded about trying different products. And
I had the patch to begin with, and it didn't work for me. It kept coming off, probably because of all the exercise. And the gel, well then I had the gel and I went on a lower dose, I think I said to you, than what I would have been on the patch. Yeah. But I seemed to feel a difference, so it was obviously an absorption thing for me. But the transdermal then, which is transdermal is the patch, the gel or the spray, because it goes through the skin. Again, that is safer. I don't want to say the wrong thing.
No, so that is it's safer in terms of clot profile. Yeah, so if you've had a stroke, for instance, or it depends what's happened to you, but lots of women who have had things like strokes where oral HRT we would try to avoid, the transdermal is considered the much safer route. Yeah.
So I think because it's difficult for Amy to answer individual questions, because obviously you've all got your own GPs who you need to consult with. But you know, I guess what you're saying is your GP will want to look at your whole history before they prescribe you what will be right for you. But then of course you need to be seeing somebody that's competent at prescribing in the menopause.
Yeah, and I think,
to feel confident.
Yeah, and I think that receptionists are really good at knowing. So I've got a colleague who's brilliant at injecting joints. So, you know, if you've got that's what's needed, they wouldn't send you to me, they'd send you to him. So I think they're really good at guiding.
Yeah. And she said, yes, she can't have it oral, so you're right. Yeah.
But I'm really glad that that's happened for you, because actually there are a cohort of women who probably have missed out on things because either the product wasn't available or, you know, people didn't know that it was safe.
Yeah.
So it's really good that you've got that.
Kerry, I went to see a GP with the Latte Lounge list, and she listened and offered me SSRI, as she viewed my symptoms as mental health based than physical. I felt let down, so I didn't go back for another maybe 6 months. She's I think she's carrying on typing, but I think that's one of the questions, isn't it? Being a lot of GPs do unfortunately prescribe antidepressants, but that's not to say that that's wrong, because I guess everybody, you know, there's a place for antidepressants, and they can work alongside HRT.
Yeah, absolutely. And I think it's no understanding what you think is going on with yourself, isn't it? And actually not being frightened to say, actually, I'd really like to explore the fact this could be my hormones doing this.
Yeah.
I know, could we consider HRT here?
Yeah.
And there's absolutely a role for antidepressants for some people, and actually for people who can't have hormones, say if they've had a breast cancer or whatever,
or cancer sensitive hormones,
then a lot of the antidepressants are really good at switching off hot flushes and treating menopausal symptoms. So
anti-anxiety,
So there's definitely a role for them, but I think if you feel like, don't be frightened to ask again, or ask to see a different doctor in your practice, because you know yourself, you know if things are changing. And you can have an inherent trust in your ability to trust your own body.
Because you might be feeling low mood and things that are associated with depression, but then there could be a whole host of other things that you could be experiencing. Absolutely. So actually there's nothing wrong with going to your GP arm to say, I want to explore the HRT route.
Absolutely. And I think I'm terribly boring in my practice, because I'm always shouting at everybody, remember, if it's a woman in her 40s or 50s who've just got anxiety, think about their hormones, you know. And I think you're okay to say, look, this is new for me, it's suddenly happened. Can we please explore this?
Okay, I can see your questions up, but I would need to answer these ones, I think, first quickly, because Amy has only literally got a few minutes left.
It's okay.
Okay, so blood tests recommended?
Over the age of 45, you don't need blood tests.
Just go by the symptoms.
Just go by symptoms. Under the age of 5, definitely. 40 to 45, we would consider it an early menopause. And under the age of 40, then it's premature ovarian insufficiency, which is it's just when everything happens much earlier. The earlier it happens, the more at risk of osteoporosis you are, of heart disease. So it's really important that we don't miss these women. The only role for blood tests is when there's some diagnostic uncertainty. So when, as we get older, things like thyroid disease is much more common, and thyroid and menopause really mimic each other. So there is sometimes a role for going, actually, I'm pretty sure you're menopausal, but let's just check your thyroid as well. But it's not, over the age of 45, you do not need a blood test. And the really important thing is, if you have a normal blood test, it doesn't mean you're not perimenopausal.
Because it's a snapshot of that.
It's a snapshot. It's just that one day. So, a normal blood test does not mean you have to wait.
So you go by your symptoms, I think, is the answer to that one. So one of the ladies tried estrogen, tried HRT, but it brought back painful symptoms of endometriosis. So she's got the Marina-Core. Is there anything else to help her go through the menopause? Would testosterone be any good? So
going through the menopause, as in symptom control of the menopause, I'd be interested to know whether or not you had the Mirena in when you started the estrogen. That would be, because if you have endometriosis, even if you've had a hysterectomy, you should always be on progesterone, because with endometriosis you can get extra uterine deposits, so you can get a bit on your bladder, and theoretically then that can grow, and the estrogen can definitely make it grow and make the symptoms come back. With that sort of situation, I would be going into it, we'd be having a very open conversation about what to look for, but be open to trying a different lower dose estrogen.
Maybe.
But it might be that you tried the estrogen without the Mirena, I don't know, or whether or not actually the Mirena would have helped stabilise things, and now you can add it back in, but go super slow.
Okay, cool. Brilliant.
So I'm just talking about HRT, I'm sorry, obviously all the lifestyle stuff is really important.
Really important, the lifestyle stuff.
I'm whipping through this stuff. Because we know that if you drink too much alcohol and you smoke, it is proven that your menopausal symptoms are worse.
And we've spoken about that, girls, haven't we? The alcohol, the palpitations, not being able to deal with even 2 glasses of wine anymore, and some of the women have given up drinking. So okay. Women who have had hormone, we just talked about that. Some of this has already been covered. So women that have had hormone-sensitive cancers. Is it better to apply to the thigh for absorption? And also, do we need to keep away from the breasts?
Always keep away from breasts. because you don't want to be...
But arms are fine?
Upper outer arms are fine. Really, it always says upper outer arms, inner thighs, or thighs and bums. It's all about surface area. So when you apply it, you want it to be applied over an area that's sort of the same as an A4 piece of paper. So, sorry, can I...
That's right, yeah.
So that sort of size. So actually, that's quite a lot of arm, isn't it? So bums and thighs are good because most of us have got a bigger surface area.
You can put gel on your bum as well?
Yes.
Oh, I didn't know that.
Yeah, just away from your boobs.
Okay.
And remember, when you're applying it, apply it like you're icing a cake, not like you're rubbing it better. Really important to rub it on, but like you're icing a cake.
Okay.
So it leaves a nice film, and then you let that film dry. Don't go too vigorous. And the big thing is, if you're on more than one pump, you don't ever go 1, 2, rub it in. You go one arm, one, the other arm. If you're on 4, upper arm, inner thigh.
You can use the lid to rub it in so you don't waste it.
Use the lid, anything that stops you wasting it.
So one of the ladies is on Sandrina gel, but she's only on 0.5 milligram.
Yeah, tiny.
Which is really tiny, and she's also she's been advised to continue with the coil, but the only reason she's on such a low dose, she's worried about the cancer risk, but we've obviously covered that, and I think maybe safely that would, I mean, 0.5 is really low, isn't it?
Yeah, I think that if you're not feeling any, I think that sometimes, I think we can be scared sometimes and end up spitting in the wind a little bit, and I think don't be too scared of pushing a dose, because if you think about when you're pregnant or when we were on the pill when we were younger, there's a higher risk profile with the pill, and when you're pregnant you have loads of estrogen all the time, and I think we're scared of something that we've probably already experienced.
Yes, so our bodies, we're replacing our body with a natural estrogen that it's, you know, long term as well, long term health, it's so beneficial. Palpitations, I know you said about, you know, that's something your GP might want to do an ECG or something.
So my approach to palpitations, and I am a bit of a dot of the I's and a cross of the T's. Yeah. But if somebody comes to me with palpitations, I'll always want to make sure that there's not a cardiac cause first. So I would want to examine them, check their blood pressure, listen to their heart, and I would get a baseline ECG. Right. You know, if it fits that my periods have gone funny, I've got hot flashes and I've had some palpitations, then on balance it probably is to do with your menopause, but my practice is all I want to make sure that it's nothing else first.
Right, okay.
Wouldn't stop me doing anything in terms of the other stuff.
Yeah.
But I'd want to make sure I was doing those things at tandem.
Okay. I'm nearly a year now without a period. I've only been experiencing really noticeable menopause symptoms about 4 months. So I'm nearly over peri and now hitting menopause. I can't take HRT due to estrogen breast cancer. Okay. So we're doing all the right things here, Ruth. And there are also lots of other homeopathic sort of routes you can go down. I know some of the girls in the group maybe can share some of the stuff. You mentioned a couple of things that you've heard some of your patients swear by, is it?
So I've got patients who swear by black cohosh and by red clover. And remember, there are some prescription medications that really help with symptoms of the menopause, like hot flashes. Some of the antidepressants, one called Menofit, which we use for anxiety and depression, but is also very good for hot flashes. And a blood pressure tablet called clonidine, and that some of the bladder drugs are very good for these symptoms. So even if HRT isn't for you currently, there are still options. You don't need to be sort of suffering with things. And that's something that is NICE approved.
Yeah, NICE guidelines. So that's yeah. Okay. Good, Kerry. So you persuaded. You went back after Marina for heavy periods. That's good. I've got no thyroid due to, I can't even read that, calorie cancer, yeah. And my body doesn't produce calcium. Okay. Am I okay on patches?
Yes.
Yes. I take supplements and fluoxetine, Prozac. Yeah. They work brilliantly for me.
Yeah.
Good.
Absolutely. And so Prozac is one of these SSRI drugs I'm talking about, and it can be brilliant. And I think this is the thing, isn't it, with this, that there's not one size fits all. No. So you have to be open-minded.
Yeah. The migraines, the lady with migraines is on.
Yeah. So lots of women find that their migraines get worse in the perimenopause, and it's because of the fluctuations in hormones. So on a Wednesday we're all right, and then we've got no hormones by the, it's a horrible cycle, and migraine sufferers really struggle with that. So what we need to try and do is even them out as much as we can. So track the migraines, see, make sure that there is this cyclical element.
I think she said, yeah, it's 3 months, it's 3 days prior to her period.
So that is, in the run up to our period, if we get pregnant, our estrogen stays high. If we don't get pregnant, our estrogen falls, quite rapidly falls. So that's probably what you're feeling. So there are women when they're younger who often take a certain sort of pill if they've got a migraine without aura. An aura is when it's coming, you might get visual disturbance, and then you can't be on a certain sort of pill, a combined pill. If you don't have that sort of aura, sometimes people run their pills back to back to avoid the dips. With HRT, it can be really good because we can just even people out. The big thing when you start HRT is you need someone to know that if you start too high too quickly, it'll precipitate a migraine. So you've got to go low and work up.
So I don't know if you're on HRT, Natalie. So, but hopefully that's answered.
The other thing to mention is that keeping your having a Mirena can be really helpful because you get a constant dose of progesterone. If you go on, if you have periods and you're on the sequential HRT, sometimes that's tricky if you've got migraines, because obviously you're going from quite a high dose of progesterone to none, and the migraine can really struggle with that. Yeah. So it's a conversation about if you need continuous HRT earlier.
Yeah. One of the ladies asking if you know of any sort of menopausal specialists in the Croydon borough.
So menopause care work, do you mean NHS? I can't, sorry, I'm talking to you.
Yeah, respond to me. Do you mean NHS, Jo? Or because obviously there's the clinic, obviously, but then...
And that's on Zoom. Yeah. So most of the kind of private clinics now work remotely. There's gynecology at Croydon University, and Dorking Healthcare are setting up a menopause service, but it's not happened yet.
That's private?
No, Dorking's not. Dorking's
okay.
NHS.
NHS, Dorking.
So it's coming.
Good, okay. Oh my gosh, there's loads of questions here. We probably need to wrap up soon because Amy has got to go. How would implant affect me? I haven't had periods for years, but I have more than enough symptoms.
How old is this?
How old are you, Claire? You're not 50. You're in your 40s, aren't you? Right, Natalie's not on HRT. I think you need to have a conversation then, Natalie, about that. She said you weren't did a blood test, said she wasn't perimenopausal yet. She's having erratic periods and loads of symptoms.
So it is okay just to say, oh, I read that. It doesn't necessarily mean that if I've got a normal blood test. I'd really like to try and, even out my migraines if I can.
Yeah.
In terms of the implant.
She's 44.
Implant lady.
Yeah, 44. Implant lady.
So it's tricky because it's a bit like when people have had a coil and haven't had a period for ages. You can absolutely, so the implant's just progesterone.
Right.
So you can really feel your estrogen going, which is your symptoms. The implant is not enough progesterone on its own for endometrial protection. It hasn't got enough in it. So you'd have to have extra progesterone on top. So you might want to start thinking, is this implant what I want? Should I have a coil instead?
Have a coil instead, maybe, Claire. Yeah.
I know I'm banging on about the coil, but it does a really good job for these things, and especially if you still need contraception.
Okay. Yeah. I have a question about that, but I'm not going to ask it.
You can ask me.
We're nearly there.
So
the thinning hair.
Oh yeah.
Hypermobile, but I think we know strength and resistance training for the hypermobility key.
Yeah, and definitely there is a role for making sure your estrogen is good if you're hypermobile. Yeah. Because the role with how it works with the collagen. Yeah. And then it'll augment your strength training. So yeah, it's really important if you're hypermobile.
So I think we've answered very quickly whether they may be progesterone intolerant. We spoke about this, V. I don't think you were on, Vida, just saying, can you tell people quickly whether they may be progesterone intolerant, how they may feel? We spoke about that.
So ragey PMT.
Yeah, ragey PMT.
Really notice the difference between when they're just on their estrogen and when they're on their progesterone. And I think it's really scary because you think, why am I all right now? And I'm like, I'm feeling so crazy. And often it is the progesterone. Not often, it can be the progesterone. When you look back in people's history, sometimes they had postnatal depression, or they might have always been a bit angsty around their period, and it can get worse.
Yeah.
It doesn't always.
But there are options, is what we were saying earlier, Vida. If you watch it on playback, no worries. So glad this information is available. I was let down in my 40s, suffered in silence, not knowing what was going on with me. It's fantastic this is being discussed. That's my sister. What about low sex drive? You can't go to the doctors about that.
You can.
You can.
You can. So remember, third female hormone is testosterone. Sex is really multifaceted, and it's not just about testosterone. It's about how we feel about ourselves. Vaginal dryness again. If you have vaginal symptoms, who's going to want to? Women are already well estrogenized and they've still got symptoms. So remember, there's no female product licensed shamefully in the UK, so we use male products. And GPs can prescribe it, but you have to be considered to be a competent prescriber. But so, you know, I prescribe it as a GP. Lots of GPs do prescribe it, and generally there will be somebody who can.
So you can.
It does need quite a lot of blood monitoring, and you have to have a blood test first. But often you have to push up the estrogen because it's a complicated breakdown thing with all these hormones, and they all work synergistically together. In the body, lots of estrogen gets broken down into testosterone anyway. So if you estrogenize somebody properly, their testosterone often automatically goes up. So I think we can sometimes think that testosterone can be the final piece of the jigsaw puzzle, but it's not for everybody.
And it, like everything, you know, not one size fits all, and that's what we've got. So we can't rule out, you know, lifestyle and factors, and we can't rule out what's the stresses in our lives that can, you know, there's always this crossover, whether it's an underlying health condition, whether it's you know, events that you've experienced in your life, I think.
Absolutely.
But you've got to go armed to your GP and no, you can have testosterone.
And it's you shouldn't be ashamed to ask about it. It's really important. We do talk. We absolutely talk to you.
New husband.
Get a new husband.
This session has been amazing. Thank you so much for talking to us.
Pleasure.
They're all just thanking you. There was only one other question that I could think of, and that was about the extreme exhaustion, all of those symptoms that one lady was experiencing. She's not on HRT.
But she was the right age.
You know, she's really good with her nutrition. I mean, so good with her nutrition. Had some CBT, been prescribed antidepressants. Didn't want to take that route though, but just feels irritable, rage, hot flushes, cold flushes, you know, but just real bad exhaustion. And
so I think my question then is always, what's your barrier with trying something? And is it a fear? Is it this kind of, you know, there was this very old-fashioned way of thinking, well, if you can't cope, you can have some HRT. It shouldn't be about that, should it? It should be wanting to, you know, live our best lives. So I would always want to explore what that barrier is. And whether or not it's a fear, perhaps it's a breast cancer fear. But it sounds as if everything is being done as it should be being done, but we're still not there. But if we really think about what happens to those hormones after the age of 40, it's no wonder that's me showing the graph. It's no wonder on this period that we feel rubbish.
So bad,
and what I do often when I'm not sure is I'll say, why don't we do a 3-month trial of HRT?
Trial it.
And if you don't feel any better, cool, we'll dig deeper, we'll investigate further. But once I've satisfied myself, I've not found anything else, and you're the right age, you've got lots of symptoms. For women who are resistant, sometimes I'll just have that open conversation and just say, what is the thing that's stopping you trying?
I think we just need more Amy's in the area, don't we? Okay, no worries. I'm going to let Amy go now. I will pass on all your thanks to her. Thank you so much for taking the time to talk to us. Thank you. It's really helpful.
Oh, good.
Thank you. Really useful session. Thank you, Amy. So interesting. We're lucky to be part of this group.
It's a great group.
Okay. Vida, thank you so much, both of you. Yeah, well, you're just getting all the thanks there.
Good.
So, okay, ladies. I will see you. I'll be back on at some point, probably tomorrow. Have a good evening, and thank you to Amy.
Thank you. Bye.
Bye.
Bye.